Good afternoon, everyone, and welcome to the Recovery Science Echo brought to you by BWell Texas and the Center for Substance Use Training and Telementoring CSTAT. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. To all the BWell Texas providers, please make sure that you identify yourselves during the session by entering your information into the chat, or if you're joining via phone, please email me your name and phone number to bwelltx@utisca.edu. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you are here today, we're just happy you're here to learn alongside us. We are recording these sessions for later distribution through the BWell YouTube Texas channel. Any info you put in the chat will not be shared on these recordings. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the emotions menu at the bottom of your Zoom screen and to raise your hand and indicate you have a comment or a question. You can also use the chat to share your perspective. There's a lot of us in this space, so please keep your comments brief to allow others to speak up as well. And finally, please note that no predictive health information is allowed in either the chat or the discussion, and that includes names, addresses, emails, or any information that can easily identify an individual. Towards the end of the session, our wonderful IT support Karen will be sending out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and also allows you to access free continuing education credits. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on economic evaluation methods for recovery support services and will be presented by Dr. Sierra Castedo. Following that, we will discuss a case presented by Cheryl Pacapelli. We will start with introductions, didactics, announcements, case presentation, and open discussion. Thank you all again for joining us today. These sessions are what we make of them, so we encourage you all to share your questions and insights in today's conversation. And with that, we will do some introductions. Sierra.
Hi, I'm Sierra Castedo de Martell, and I am one of the hub members.
Thank you so much for joining us today. Cheryl.
Hi, Cheryl Pacapelli, person in long-term recovery and hub member.
Thank you so much for joining us. Emily.
Hi, I'm Emily Hennessy, and I'm a hub member.
Thank you so much. Daniela.
Hi, all. I'm Daniela. I'm the project manager for the Peer Recovery Innovation Network grant.
Thank you so much for joining us. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm a CSTAT program coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics. Sierra, you can take it away whenever you're ready.
Great. Thank you so much. I am just going to go ahead and share my screen. Everybody see that okay?
Yes.
Great. So my name is Sierra Castedo de Martell. I am a person in long-term recovery from substance use disorder. I used to work in collegiate recovery and thus in direct services, but I'm now in the research realm. And so I kind of bring personal, professional, and now research experience to this realm. Today, I'm going to be talking to you about economic evaluation. And I will also stay with you for the case part. Here's my disclosure statement. No financial relationships with the commercial interest to disclose. And these are my views, not reflective of UT Health San Antonio. By the end of this talk, you'll be able to differentiate between different common methods of economic evaluation. You'll be able to do a basic interpretation of the results of a cost-effectiveness analysis. And during our case study, we're going to dive into using a cost-effectiveness calculator for peer recovery support services and for bystander naloxone distribution. That's what these two acronyms stand for. And then you're going to identify some ways your organization might be able to engage in some economic evaluation to support your work or your research. My presentation today is going to be organized into 4 main parts before the case presentation. First, we're going to cover what is economic evaluation. Then we're going to give an overview of common methods, and that's where we're going to spend most of the time today. And I'll leave you with a brief overview of kind of the kinds of information you need to keep track of to do one of these. And then also some resources. I'm just going to leave you with a bunch of them. We're not going to go through all of them. And then we'll go into our case. So some of you might have seen this hierarchy before if you've been trained in systematic program evaluation. Whenever we're setting out to evaluate our programs, we want to start out with a needs assessment down here at the bottom. What's the problem? What's its scope? Maybe we find out what some of the determinants are, how we're going to impact this problem. And then we want to design our programs based on the evidence, and we might evaluate the program's theory and design to make sure that it's sound. Then we're going to look at the processes of our program. Are we reaching the people that we intended to reach and that we know we need to reach thanks to our needs assessment? Are we adequately covering all the populations impacted by the problem? Are we doing the right number of activities and the quantity we mean to, all of that? And once we've done that, we can look at the outcome or the impact of our program. Is it actually working? Is it having the desired effect? So all of these parts are kind of dependent on the parts below them in order to be able to do that next kind of evaluation. And up at the very top, we have efficiency evaluation or economic evaluation. Really, we're getting at this idea of efficiency, though. That's all the way at the top because we really need to know at least something about all of these other pieces before we can do that kind of evaluation. For the main question that we're trying to answer with economic evaluation or efficiency evaluation is about our intervention, which has resources that go into it to make that intervention happen, and then good stuff that comes out of that intervention. And we want to know how balanced those two sides are for any intervention. And I want to give a caveat here because over and over as a society, as individuals, we choose to do things that are inefficient all the time because we've decided that they're worth doing. Is having my 4-year-old help me make pancakes an efficient use of resources? Absolutely not. He's going to drop at least 1 egg. He's going to spill tons of flour all over the place. But is it worth doing? Absolutely yes. And we do that on a societal scale too. Economic evaluation's just one tool in the toolkit to help policymakers make decisions about where to allocate resources. And we want to make those kinds of decisions, not just because we want to be good stewards of resources, but we also want to maximize the number of people that we can help. If we put our resources into inefficient uses, then we're not necessarily going to be able to maximize the number of people that we help in the same way. So here are some of the methods of economic evaluation that you might have heard about. You'll see a lot of these terms get used interchangeably, even though they're not necessarily interchangeable. This top row right here is just telling us about quantifying the costs, while this bottom row is looking at both costs and outcomes, or the good stuff. So that means that this bottom row includes methods that are truly looking at efficiency, that balance of resources in and good stuff out, while that top row isn't really efficiency. And we're going to go through each of these squares briefly, but I'm actually going to save cost effectiveness last because that's going to lead us into our case presentation. So cost of the illness or cost of the problem is just what it sounds like. It might help us make the case for a program or inform a needs assessment, but it's not really telling us much about efficiency. We want to think about direct costs, like maybe the healthcare costs for treating substance use disorder, but also indirect costs, like maybe the cost of lost productivity due to substance use disorder, which is a little harder to capture. We might want to include things that are even harder than that to capture, like opportunity costs or broader societal costs. The cost of the program is also pretty much just what it sounds like, what a program to address that problem might cost. We can simply look at what it costs to pay people to do that work. So like labor costs, we might look at supplies, and anything that kind of covers the day-to-day operation of an intervention. But we also might want to think about implementation costs. So what it costs to start up, or maybe have somebody consult to help us get a program going. So those might be kind of maybe more one-time costs rather than costs that are more ongoing and recur over and over. We're often thinking about labor, staff salaries, overhead, direct and indirect costs. We also might want to think about the time that a person might spend in our program getting helped. We have ways of assigning that value too. And when we're thinking about cost savings, we're actually getting a little bit closer to this idea of efficiency, but it's still not that whole efficiency picture. If we implement this program, how much of the cost of the problem can it avert? We have to incorporate some of the outcomes from that outcome or impact evaluation, right? I need to know, for example, how many hospitalizations my program might help avert. And then I can estimate how many dollars are saved from that, right? But I'm not necessarily able to incorporate other outcomes that maybe don't have a really clear dollar value. And I might not also be looking at different perspectives. So like who is saving the costs? And I also might not necessarily have a way to incorporate people's quality of life in here or impacts over time. So that's why we want to move into methods that do get us a little bit more of that big picture, that do let us look at what goes into the program and what comes out of the program. And so we're going to start with these other two methods first, cost benefit and return on investment, and then we're going to circle back to cost effectiveness. And these are all of the ones that help us really look at efficiency. So cost benefit analysis involves setting up a ratio, just like it sounds, where you tally up all the costs involved, and then you tally up the dollar value of the benefits that are added by the program. So your result's going to be a ratio of benefits and costs, or costs and benefits. It'll often be reduced down into a single number. So for example, it might look something like this. And we would read that as, for every dollar spent, we get 3 cents more in benefits. It might look something like that. But here's the thing that's really tricky, and why we're going to focus in on cost effectiveness, why our case presentation is about a cost effectiveness calculator, why we might want to use a different method than this for recovery research. And that is because we assign a dollar value to both that cost side, of course, but also to the benefit side. And it's not really straightforward to do that for recovery research in particular. There's an established way to do this in health economics. We translate all of the good things that come out of our program into something called quality adjusted life years. Quality adjusted life years, it's just this idea that there's some kind of intervention, let's say chemotherapy, right? Where there's going to be side effects, and maybe it might add years to my life, but it might also change the quality of that life, maybe just temporarily, maybe long term, right? So we want to have a way to quantify that quality of life in addition to that quantity of life that it's adding. And so we would add some kind of adjustment, right? So maybe a number like 0.5 indicating that the quality of those life years that were added by this intervention, they're half as good as being in perfect health, right? And then in cost benefit analysis, you'd assign a dollar value to those quality, to those life years themselves. So you're able to kind of layer a dollar value on top of that quality of life adjustment. Now, for recovery, how sure are we about assigning that quality of life value for recovery? We actually have some really fantastic measures that measure recovery quality of life, but they're not set up to easily be converted into a number like this, 0.5, for estimating those quality adjusted life years. They just weren't designed with that purpose in mind, and that's okay. We get a score from those existing measures that we have, but that score doesn't translate into qualities directly. Unless we do a mapping study, and that's actually something I'm in the middle of right now. A lot of previous health economic research on substance use really ties that quality of life measure to simply not using substances, which is fine, but we know that recovery from substance use disorder is a lot more than that. So right now, we're not really in the best place to not only assign a quality value or quality of life adjustment, but then to layer a monetary value on top of that. So that's why I avoid that, and we'll talk more about that in a minute when we get to cost effectiveness analysis. Return on investment, conceptually really similar to cost benefit analysis, but usually we're just talking about a narrower focus. So it might just look at financial costs rather than those broader societal costs or what we call economic costs. And again, it's set up similarly to cost benefit analysis. So there's going to be a dollar value on both sides of that equation. So we kind of have that same issue. How do we assign dollar values to things like recovery? So that's why I like cost effectiveness analysis. Let's take a look at the basic formula for cost effectiveness analysis. I'm going to point out first that you see the word cost up here on this top line when it comes to the cost of the intervention and the cost of treatment as usual, but you don't see costs down here on this bottom line where we're dealing with the effects or outcomes or the good stuff that our intervention produces, right? And this basic formula, we first find the difference in costs between our intervention or our program and the cost of what people typically do, how we typically address the same problem. And then we divide that by the same difference in effects. But we let effects stay in whatever the unit that we measured it in. We don't try to assign a dollar value to those effects at all. That gives us a result called an incremental cost effectiveness ratio, sometimes shortened to ICER. And the way that we read that result, it might look like a single number, like let's say it's $500 or $30,000, but then it's always in terms of some unit. So it might be $500 for every sick day that we avert, or $30,000 for every year of life that we add. So that's just generally speaking what our result's going to look like. And you can think about our cost effectiveness result kind of like using price per ounce or price per pound at the grocery store. So let's say I walk into the cereal aisle. I don't really care what kind of cereal I get. I just want to maximize my breakfast dollars. I can compare the price per ounce across a ton of different kinds of cereal that are in very different kinds of packages. I can compare the bagged Lucky Charms knockoff to a small box of Oat Bran, right? And if I look at the price per ounce, I'm able to see that even though this 15-ounce box of Cheerios, costs almost twice as much as this 12-ounce box of Oat Bran, I'm able to actually make a much more direct comparison when I switch over to using that price per ounce. And I see that the Oat Bran is indeed a better maximizer of my dollars for breakfast. Now, thinking back to the caveat that I gave you at the beginning, let's say I just decide I really like Cheerios and I want to go ahead and buy Cheerios. And I know that I'm making the less efficient breakfast choice, but that's okay because that's just what I really feel like having this week. That's okay, right? I get to make those kinds of choices, but I'm making that choice with that information in hand. And maybe in times when my grocery budget doesn't look the same and is a lot more restricted, well, then I have the information I need to make a more efficient breakfast choice and really maximize my dollars, right? So I can also look at different scales of the same exact thing. So I know a lot of us, when we walk into the grocery store, we see a larger package, we assume that's probably going to be cheaper per ounce, but actually sometimes it's not. We may think the same thing about health interventions too. If we do it at a larger scale, surely there'll be efficiencies in being able to do it at that larger scale. Sometimes that's not the case though, and cost effectiveness analysis is able to let us kind of break down some of those differences and be able to kind of directly compare things that are of a very different scale. So in this example, actually, my 44.5-ounce jar of ketchup is actually more expensive than the smaller 35-ounce jar if you break the price down per ounce. So again, just to kind of sum up, at the top, all of my costs, those get a monetary value. Down here at the bottom, all of my effects, I do not assign them a monetary value. And thinking back to our discussion of some of those just cost-oriented methods, I want to look at costs at least a couple of different ways here as well. So for cost effectiveness analysis, we always want to look at the societal and the health system perspectives as much as is practical. For societal, that's really big picture. I'm looking at all of the direct and indirect costs that go into this problem and into making these programs happen. And then also I might want to look at a smaller perspective, which we usually think about as health system, but it can be really anything as long as it's a narrower perspective. So just as an example, when I did this for collegiate recovery programs, I actually used the college health campus as the health system perspective because those are the people who are providing the service to students. On the effect side, I want to look at, there's those pesky quality adjusted life years again. I do want to look at those. That is so that I can compare whatever intervention I'm looking at directly to interventions that might be totally different, right? I could compare flu shots to dialysis if I wanted to, right? Because I'm reducing them down into the same unit. I'm looking at cost per QALYs. Just FYI, when we look at QALYs, that's technically a cost utility analysis. That both terms are correct. It's just a more narrower definition. But then also, ideally, I want to look at something that is more meaningful to the stakeholders of the intervention that I'm analyzing. So that might be people in recovery. That might be a change in recovery capital or BARC 10 scores, right? I could keep this in those units. And so I'm looking at a dollar value per unit of whatever kind of outcome I get to choose, right? Just as long as it's something meaningful to my stakeholders. All right. So once we get our result, our ICER, what does it mean? How do we interpret it? Well, we compare that result, that ICER, to some kind of preset number, and we call these willingness to pay thresholds. Now, these numbers here, 50K, 100K, 200K, these all come from kind of standard practice health economics in the US. When we first started covering dialysis under Medicaid in this country, of course, it was a little controversial. It was pretty expensive. And at the time, back in the 70s, it cost about $50,000 every year. And because dialysis, you need it to continue to live, we basically determined that the government's willing to pay $50,000 for every life year added, right? We know the government's going to at least pay that number. These two numbers basically represent inflation since the 1970s, since we established that 50K number. Now, that kind of stuff is kind of more for the health economics crew, right? We also want to pick a number that is smaller and usually something that is more meaningful to our stakeholders. So in our kind of work here, maybe we want to pick the cost of another specialty treatment episode for substance use disorder. Or maybe it's the cost of a hospital stay for a non-fatal overdose, something that is relevant and means something for our stakeholders. We then compare our result to those numbers, and if it falls below it, we can say it's cost effective to that threshold. If our ICER is below 0, that means it's cost saving and cost effective, but we actually have to double check why it's negative. If our top number is negative, right? If our intervention costs less than treatment as usual, and our bottom number is positive, our intervention gives more good stuff than treatment as usual, then that's good. Then it's cost saving and cost effective. If it's negative for the opposite reason, it costs more, but it does less good, well, that's not so good, right? So we always want to double check why we're getting a negative ICER. So we are done with our whirlwind tour of economic evaluation, and I'm just going to move quickly into some next practical steps for you and leave you with some resources, and then we'll transition into our case. If you want to get involved with economic evaluation, and let's say you're already running some kind of effectiveness study, or you're already running a program and you do outcome evaluation, well, make sure you're keeping track of all your normal outcome evaluation stuff. Ideally, it would be great if you could also, if you're also asking questions about medical care that people are getting outside of your program, the number of times they were hospitalized in the last month, things like that. It would be also great to use a quality of life measure that's quality compatible. And I've left some in the notes for you. That would be things like the PROMIS Proper or EQ5D, EQ3D. There's a bunch to choose from. And then also on the cost side, we want to know what service utilization looks like. How much are you paying for labor? How much labor are people actually using when they participate in your program? All of those kinds of things. And then I've got some great 101 type resources. A big plug for Cherish. There's a free consultation service through Cherish, which is a NIDA funded center focusing on health economics research for substance use disorder, HIV, and HCV. And then I have some more advanced resources for you as well, but I'm not going to go through all of them. You'll get these slides. And that is it for our whirlwind tour. I think we have a couple of minutes for questions before we move into our case.
Thank you so much, Sierra. Thank you for the wonderful presentation. I will open up the floor for any questions or comments from our community here. You can stop sharing the screen.
Thank you.
Thank you.
Somebody has their hand up, I thought. Ralph, could you unmute?
Yeah. Are there benchmarks for these kinds of ratios or effectivenesses?
Yeah, so the willingness to pay thresholds are kind of act as those benchmarks, right? But then it's also useful to compare to other types of programs that might be similar, right? So for something like an RCO for peer recovery support services, we might want to compare to what was the cost effectiveness result for a psychosocial intervention of some kind, right? For psychotherapy, for motivational interviewing, things like that. Oh, and I apologize. I forgot that my hand gestures are getting recognized. So apologies if you saw all sorts of weird emojis coming up while I was gesturing. So it might be useful to kind of look in the literature, whoever you're working with, have them look in the literature to see if there's other studies where we can see, kind of how our ICER, our result, compares to what others have found. That's the nice thing about cost effectiveness analysis is we do get to make those comparisons, right? If we do the analysis in terms of QALYs, then we can very directly compare to other interventions, even if those are really, really, really different than ours.
Okay, thank you.
Thank you, Sierra. And we'll keep the questions coming in the chat. We'll keep the discussion going there. But in the meanwhile, we will move on to the next part of our session. Thank you again for the wonderful presentation. Karen, if you could please bring up the announcements from BWell. To claim your credit, you must text by midnight tonight. Please text attend 1009-5346 to 844-502-1338. You must text by midnight tonight to receive your CME credit. Next slide. Do you have a research or evaluation, a related work in progress that you would like to receive feedback on? CSTAT offers you the opportunity to present your research or evaluation related work in progress and receive feedback from a community of experts. There is no need to prepare a formal presentation. We will be giving you a case form to assist with this. Please email us at cstat@utisca.edu. Next slide. The Texas Symposium is happening next week on February 29th and March 1st. we only have the in-person registration is all sold out, but virtual spots are available for this free event. So please visit texas.org to register. Next slide. The Peer Recovery Innovation Network that helps in bringing this ECHO series would like to learn more about your interest in recovery science. PRIN aims to expand the science of recovery through collaboration and engagement. Please take the brief survey that we will be sharing right now in our chat. So we really appreciate if you could complete this survey using the link in the chat. Thank you. And with that, we will move on to our case for today. Karen, if you could please share the case, and Cheryl, you can take it away when you're ready.
Great, thanks. Okay, thank you so much, Sierra. I so appreciate your presentation today. Again, my name is Cheryl Pacapelli. I'm the project director for Peer Recovery Support's facilitating organization at Harbor Care in New Hampshire. And just so everyone knows, the FO just oversees the subcontracts for the state of New Hampshire to 20. Now this says 20, but we actually have 21 different locations. So we're 100% grant funded with both federal and state dollars in this. So we have been collecting data since 2016 when we started in many different forms, but currently we use our electronic health record as Recovery Link, and we have been working with them for the last approximately 3 years. So we have some consistent data across the state that every RCO has to do peer recovery supports in the same way, recording their data in the same way, using a BARC-10 and intakes and baseline measurements and outcomes. So when we saw Sierra's tool, we were like really excited about it because like we know from talking to people that what we do works, but we never had a way to kind of measure it. So we took our data and we popped it in that tool, and then we said, well, what does that mean? Like, we didn't really know, like, is this really good? And so today what we're asking with this case is that we put our data in the tool and have Sierra help us to analyze what we have and what we do here in New Hampshire. So that's the case. And we want you to ask questions because like we have the experts to answer it. Like this is the time, ask the questions. So great. So now, Sierra, you're going to bring up the tool.
Yes. Yep, I'm going to put it in the chat box as well. So you can follow along, you can play around with it yourself. I'm just going to do a really quick orientation to the tool. And then we're actually going to plug in Cheryl's numbers and interpret. So when you follow the URL, it'll take you to this page. There's 3 tabs across the top. This first one is for PRSS. That's the only one we're going to use today. And PRSS is Peer Recovery Support Services. Sorry, I'm just assume we all know, but you never know. Naloxone tab is for bystander naloxone distribution. And then I also want to point out the tutorial and resources page. A huge thank you to my partners in this. I didn't make this alone. Margaret Moore was the lead on the naloxone component, and our fearless leader was Dr. Brown. We did this at UT Health. This was part of my dissertation project. And then also importantly, I know we have some folks from one of these organizations here today because I saw Phil in the audience. Communities for Recovery and Recovery ATX were 2 Austin RCOs that were absolutely instrumental in making sure that we were building this thing right, that we were conceptualizing these services correctly, and then actually like pre-tested all of the components. Would not have been possible without them. So huge thank you to those 2 RCOs. And Okay, with that, I am going to stop sharing and turn it back over to Cheryl, who's going to show you what it looked like to put all of her information together to use this.
Yeah, so let me share my screen. Let's see, did you get it? My screen, you're seeing
Yep,
like
I see it.
Excel spreadsheet, right? So the data that we're going to present to you was from calendar year 23. So January 1st, 2023 through December 14th is when we pulled the report to get ready for this. So during that time, we served 3,776 individuals, unduplicated. Okay, so our next question in the tool is what percentage of participants are retained to 1 year or to successful completion of long-term recovery support services? So we didn't have a really good way to get that number using our EHR. So what we did is we took our total number of intakes we did in January and then looked at that, which was 87. And then we looked at how many of them were still engaged in services in December, and we had 57. So that gave us a total of 65%. So then the next question is, of those people that were retained, what percentage of participants are still in recovery at graduation or 1 year? And please use your definition of recovery or success that your organization uses. So we define recovery here as however an individual defines recovery, and our EHR does not look at sobriety or abstinence as a recovery baseline. So it was hard for us to get this number because we couldn't match 1 year length of engagement. So we used Recovery Link has a beta dashboard that we were able to use, and we were able to pull this number to be 79% from that dashboard. Our average age of our participants is 40 years old. And then what is the average number of engagements that your participants have with their peer worker over the course of a long-term peer recovery support? And we came up with that by the number of individual services we've provided plus group sessions, so plus individuals and group sessions to the number of unique people. And we came up with an average of 9 sessions over that almost year. And what is the average length of a person's engagement? So how much time are we spending with each participant? So this came to 35 minutes, and then we added 10 minutes for doing our data entry and things to record the recovery goals and everything from that session. But just to there's a little caveat in that as we count what is called a brief check-in in there, which could last 5 to 10 minutes. So, so that number, I think that number would be higher if we did just individual coaching sessions, but that's where we got the number and how we got it. And then what is the hourly pay for a peer worker? So we had done a survey in 2023, and our RCOs paid between $18 and $24 for a recovery support worker, certified recovery support worker. So we used the number 20 for $20 an hour to put that in. We did not include any benefits that people may or may not get either in that number. So now I'm going to stop sharing and give it back to Sierra and see what it looks like.
Okay. So here we are. So all of that sounds good. We just peek behind the scenes, opening the curtain. We did review those ahead of time just to double check. But one thing that I think we might want to tweak is that for the hourly pay for peer workers, it would be good to go ahead and include fringe in that, right? So like, let's say, so benefits, things like that. So let's say the benefits at our organization is 30%, we might want to increase that $20 an hour by 30%. And for somebody who does a lot with math, my mental math is terrible. If anyone wants to give me that number, great. Otherwise, we can just go ahead with what we have here.
Somebody can do that.
Yeah.
Right.
I did want to go ahead and say that, so I went ahead and entered all the numbers as Cheryl was reading them. But I also wanted to point out, this is a fresh tab. You can also just hit default values if you just want to play around with it. And it's going to plug in each of these numbers is from the analysis, the base case analysis that we did that is going in the publication, which is under review. The only number that's different is 1,000 is just an arbitrary number. And then ideally, you have your own numbers that you can plug in and use yourself. Okay. And thank you, Emily, for doing the math. Here we go. So now we're going to hit submit. And we're going to scroll down and check out our results. I'm going to make this just a little bit bigger on my screen. So you'll note here, there are two tabs, societal perspective and health system perspective. And remember back to the didactic part, this is a much broader perspective. This is a much narrower perspective. And that's kind of reflected in averted costs. This first bullet point here is way smaller in health system perspective compared to societal because it's just looking at a smaller thing. I see a hand raised. Phil, do you want to jump in?
Yeah, I just wanted to say, could you clarify with regards to what you're talking about is a figure of not what people are actually getting paid, but what the cost is for a full-time employee that's a certified peer specialist.
Yes, but not just by your organization though, right? Because there's lots of different ways to think about that. So if it's like, okay, it would be the cost to our organization. Well, if they're paid under a grant, then it's, not costing us anything. But yes, that broader sense of the cost. So their pay, and then if they're getting benefits, what those are as well on top of that. Does that make sense?
Right. So like the indirect cost and the cost of doing business, if you will.
Yeah. Cool. Okay. So we have a set of results here that are not ICER first. We're getting we just thought that these would be interesting to you and they might be useful in addition to kind of that main cost effectiveness result that we talked about earlier. So we have averted cost to society. Over on the health system side, we have averted medical costs. And that's really just taking, from the numbers that you told us, okay, here's your number of people. You gave us the percent that are retained. Okay, so here's that smaller number of people. And then the percent that are in recovery, which is operationalized in this calculator as it can accommodate reduced sustained use, it can accommodate abstinence, it can accommodate, a lot of different stuff in there. So we've taken that smaller percentage still, that's still in recovery at the end there. And then we've just factored in from what we know about the impact of peer recovery support services, reductions in things like medical costs, reductions in criminal legal system involvement costs, all of those kinds of things are packaged into the reduction in these averted costs to society. And importantly, we're comparing here to specialty treatment. That's what we're calling treatment as usual, even though a lot of people don't get specialty treatment, right? So treatment has an effect. It does produce good stuff, right? It does impact people positively. So above and beyond what treatment does, this is how much more people in PRSS would be saving society. We also look at, we have broken out here, additional years of life added. We also have down here number of people who are in recovery to 3 years, which is kind of a critical threshold for risk of returning to chaotic use. If you make it to 3 years, you'll probably be in recovery long term. And then down here are those main cost effectiveness results, those incremental cost effectiveness ratios. And below each kind of subsection, we have it in terms of QALYs. We have it in terms of number of people in recovery. We have those thresholds, and it tells you yes or no, is it cost effective to this threshold? So we have those standard ones. We have the cost of another specialty substance use disorder treatment episode. That's that lower, more meaningful threshold. And then we also are able to run the quick test. Is it negative for the right reason? And yes, it is. So it's cost saving and cost effective. And we've got the same set of results here, but in terms of people in recovery, the number of people in recovery. Emily, yes.
Yeah, just a quick question. So about the cost saving being negative for the right reason. So that's something that kind of happens in the tool itself. It's not something that you all would have, like that Cheryl would have to go in and figure out. It's like built into the way this produces output. Okay.
Right, exactly. Yeah. So if you look at here on this fresh tab, I haven't actually told it to do anything yet, right? So once I hit submit, then it's telling me. So in our base analysis, we did not come up with a negative value in our base case, kind of an average aggregate picture. We were also purposely being very conservative in all our estimates because we, things like choices like setting it up as a comparison to specialty treatment. We know the reality is most people don't get specialty treatment, right? So we purposely made a lot of choices to make this as conservative as possible. So when you see really good looking numbers like this, I mean, you're doing good work. Yeah, it's because this is still a really conservative estimate. This picture over here, I wanted to point out as well. This little triangle will move depending on what you put in, and it just shows where you fall in comparison to these other commonly recognized medical treatments. These are all in terms of QALY, right? Quality adjusted life years. That's the one that lets us compare across very different kinds of interventions. And if we look over at health system perspective, we're getting the same set of results, but it's all in terms of the health system perspective. And so our averted costs are medical costs only, and then our numbers will all look a little bit different. Okay. What questions do folks have? Or any thoughts or suggestions or anything else you want to discuss? I know I can pull up the.
So Sierra, I just love seeing these numbers. So thank you. But my question really isn't around this, but during your presentation, and I don't remember hearing it before, but you said something about being QALY compatible.
Yes.
So is the BARC 10, which is what we use, QALY compatible? Because all those things you listed, I never heard of.
Yeah. So it's not. The BARC 10 is not. Many of you may be familiar with the National Recovery Survey. And in that beautiful study, great paper from a few years back on changes in quality of life with length of time in recovery, that quality of life measure is not QALY compatible. But so the pilot project I have right now through Cherish is to map those QALY compatible measures onto the one used in the National Recovery Survey. It's called the EuroHIS-QAL. It's 8 items. It's embedded into the SAMHSA-GPRA. So it's a pretty commonly used one. And then eventually extrapolate that out to the BARC 10 as well. And what we need to do with that, it involves collecting all of the measures of interest at the same time in the same group of people So we piggybacked on an existing study to do that, and then basically just doing a whole bunch of math to kind of map them onto each other and develop a way to kind of match the two up. That is preferable, I think, because things like the BARC-10 are a really useful tool, not just like for researchers, but like, I don't know. I mean, I know in my own recovery journey, like answering things like the BARC-10 was a really helpful way to reflect on my own recovery journey, and like it's a way to check in, right?
Yeah.
Rather than it just being for the purposes of research. So we don't want, like, I don't want to diminish that at all. And I think it's way preferable to keep doing what you're doing, keep using the stuff that works and is accurate for our population,
Yeah.
and then map that on to something that can fulfill the quality needs.
Okay.
And Jason, you've got your hand raised.
I know we're at the end. Just wanted to see if you could share your contact information. I definitely would love to pick your brain at a later date. Thank you so much for your knowledge and time. I really appreciate it.
Absolutely. And I think the slides get sent out with this too, right?
That's right. That's right. Thank you.
And so that'll have my email on the last slide as well. Emily.
Yeah, thanks. I was going to see if anybody else had a question, but I will ask my question. So Cheryl, I wanted to ask you, because obviously in working to try to get the numbers to answer some of these questions, you all had to kind of think through, what does this look like for our organization? Can you talk a little bit about that process and kind of how you arrived at, okay, this doesn't exactly match what we have, but here's how we're going to back into getting this number so that we can use the tool?
Oh, for the data that we pulled? Yeah, that was, so Alyssa, who is not on the call today, is our data person. And we spent some time with Sierra about like, this is what we can get. And, and the other thing that we did was, which was really helpful for me, because I was like, oh, it doesn't really fit. Are you sure? Is when we like say our total intakes who were still engaged, if we messed around with that percentage and brought it down to like 40%, it didn't have that much of an impact on the tool. So I felt like, even if we're not going to do a scientific study on this, right? But so we went through it that way, looking at our full, what we call a ISR report that has everybody's data in it from Recovery Link. And then we found that the best way would be if we saw you in January and you did an intake and somebody else did a coaching session with you in April or December, we were going to say you were enrolled that whole time. Now, certainly there could have been a person or two who enrolled at one center in January and then enrolled again in a different center in December, and we did not sort through all of that. So things like that. And then the other stuff was just like working with Sierra, this is what we have access to data. So if we put individual and group together, and then we see how many clients or participants we had, we can get a number of an average. So, but like I said in the beginning, I wasn't paying a whole lot of attention when the data people were talking, but I did notice when I got tasked to do this, that number of 45 minutes per person is, we're going to rerun it actually when Alyssa gets back, because I'm sure that number is more like 75 or 85, because it's taking into account 10-minute sessions and hour sessions. So, does that help answer? And I know somebody in the chat had a question about how much peer workers are paid up here. And Like no one is getting paid $36 an hour, but that's out of their actual paycheck, right? But if you include benefits to a $20 an hour position, it comes out to that your organization is paying about $36 an hour. But we are blessed in New Hampshire. We have advocated a lot for fair and equitable pay, and we have a lot of support for that, that this role, you can talk about it being how important it is, but you also have to be able to support it. And we do have a lot of support for peer recovery support up here.
Yeah, the $35 number from the default, that is from our original, our original analysis, which incorporates all of the reimbursement rates too. So it looks at all of the different reimbursement rates across the various states, as well as all of the hourly pay information that we could gather. So it's definitely a little bit inflated. But again, in trying to do the most conservative version of our analysis that we can, if we, model peer recovery support services is a little bit more expensive than maybe it actually is, that's still, that's a more conservative way of looking at it, right? And all of that is good in kind of making the case, even when we kind of hold it to like the strictest standard and the strictest interpretation and model things in kind of the least flattering light, it still comes out looking good because these are great services, right? But that just kind of helps us, helps our case be a little bit stronger as well.
So, and I guess the question I get asked is, if this is cost effective, cost savings, cost anything, which it's all of them, when does that ever show up in the state's budget? Like, and my response is, well, my data is from today, and yours won't come out for another 3 or 4 years. And that's when you would, I don't know if that's accurate, but that's what I always say.
Yeah, I mean, that's a great question, right? Are they necessarily looking at the amount of money that the state maybe spends on emergency department visits or criminal legal system costs? Are they necessarily like always attributing that any changes in that to the same exact sources, right? Not necessarily. What a tool like this can help do is to say, well, sure, you may not see it like as a line item on your budget next year, back to you. But this is how much across all of these different categories that you might be saving, whether or not you actually like can see that very directly. That's the kind of case that we're hoping to make to policymakers, right? Is to try to illustrate some of those things that they don't see as visibly right in front of them, right?
Yep. Good, thank you.
Well, this has been a wonderful discussion. Thank you all. And in the interest of time, I will request Emily to summarize today's session.
Thank you, Shreya. I will try to. This was fantastic. So, Sierra, thank you for a presentation that really just highlighted the different ways that we can think about looking at whether or not programs are efficient. I didn't realize there were all those distinctions and the ways to do that. Really lovely that this came out of dissertation work, because I think a lot of us want something like this to come out of our dissertation work, and that never happens. So it's great that we can apply it to this work. And it was really wonderful for all of you to have the example that Cheryl provided, just to get a sense of how to put those numbers in, how to think about those from an organizational perspective. And I'm hoping that some of us take away, if we're not measuring these things now, we should start so that we can plug these into the tool in the future so that we can get these kind of results. So I think the link to the tool is in the chat. There's lots of resources that Sierra has provided us with. So I will end there, and just a huge thank you to everyone and for their questions as well.
Thank you so much. And thank you all for joining today's ECHO session. As a reminder to earn CME credits, please make sure to text attend 10095346 to the number on yours in the chat by midnight tonight. Also, please complete the post-session survey, and also please complete the print survey so we know what topics to prioritize in the upcoming sessions. If you would like to present a case, please email the BWell team at cstat@utisca.edu. We look forward to seeing you at the next session, which will be on Wednesday, March 20th at 12 noon Central. Thank you all and have a wonderful rest of your day. Bye-bye.